Hello, everybody. Welcome again to another edition of the MCHD Paramedic Podcast. This is Dr. Casey Patrick, and today we are going to do part one of a two-part series that we have planned that came about really by accident. And I like these accidents. If you're a Bob Ross watcher, happy little accidents, like happy little trees. I don't know. Anyways, sometimes you find literature and evidence that supports your preconceived notions, and that can be a sign that, hey, maybe there's some bias creeping in. But I don't believe it's the case with these articles. And you may say, oh man, articles again, Patrick, going to put me to sleep. And no, it's not. Airway management's a cornerstone of what we do here at MCHD. We spent the last year talking about UE scopes and video laryngoscopy and recording these and watching them and getting feedback. It's crucial that we stay up to date with the current literature and the recommendations. So we're going to review some recent airway-related articles and discuss how they might impact everyone in EMS, all y'all listening, and specifically impact some of the reasons why we do things here at MCHD. And it's always nice to find data, actual real-world support for some of the things we think, why we do what we do. We'll let y'all be the judges of whether or not this supports our protocols. I think it does, spoiler alert. So the first paper we're going to discuss is one that looked at intubation in out-of-hospital cardiac arrest. So this is a common question that we get as medical directors, and it boils down, Dr. DePasquale, I know, has gotten it over and over again. Chief Smith's gotten it, and that is, why do we use supraglottic airways or IGLs first in our cardiac arrest patients? Why aren't we intubating them? Pretty common. I know many of y'all out there have asked me that. So the title of the paper that came out in April of this year is Risk Factors for Failure of First Pass Success During CPR in Out-of-Hospital Cardiac Arrest. This was Galinski et al. From Resuscitation, April of this year. And who were these people and how was the study structured? It was a multi-center French studies. It looked at airways from 2017 to 2018, so there were no COVID in there. It was adults who were intubated after cardiac arrest in the pre-hospital setting. Who did these intubations? I think this is a pretty important piece here, is this was mainly physician intubations. Over 90% of the intubations in this study was physician intubations. Half of those in the study had over 50, so these were fairly experienced intubators. They used no drugs. So this was a pretty classic out-of-hospital cardiac arrest situation. Anything you want to add, Chief?
Yeah, do you remember, was this direct laryngoscopy? Was this DL? Was there VL involvement in this?
This was primarily DL.
Okay.
Primarily DL, except for a couple. So this was what would have happened in our service, probably in 2010, would happen in most services in 2017 to 2018, most folks would have been intubating cardiac arrest with DL. Now, in that decade since, we've had, thankfully, a movement towards VL, but I believe there's still some learning points here that matter. And the big one is that these docs, with majority of them having over 50 attempts, performed pretty poorly. Their first pass success was only 66%. So only 2/3 of the time did they get it on the first attempt. And you may say, but that's DL. That's the old days. That's what Dr. DePasquale is saying over there. And I would say yes, but here's where I believe there are some points that matter to us. And these are the risk for failure and what helped them. Dr. DePasquale, what were the risks for failure? And you could have gotten these without ever looking at the outline or looking at the paper. That's what I like about this. It's
yeah,
cool.
I mean, I think the risks for failure are obvious to anyone who's ever tried this, right?
Yep.
Have you ever tried to intubate someone who's in cardiac arrest with CPR ongoing? The biggest risk for failure is chest compressions were happening.
Huge.
Has anyone ever tried to look at the airway and pass the tube with it moving up and down 100 times a minute? It's not easy. So I get it.
And when you push on someone's chest 100 times a minute who just had cardiac arrest 2 hours after eating their Golden Corral lunch,
that's right.
What's going to happen? They're going to vomit. We also live in Southeast Texas, so it could have been Luby's. Male, bigger probably in size, I'd say, is part of the risk there.
Big floppy tongue.
Yep. Small mouths, shocker. We all look for that and know that's an airway risk. If they have an ENT diagnosis, shocker, makes it harder to intubate.
Jaws wired shut.
And the last one that I thought was worth noting was that the more inexperienced folks did worse. So are any of those ones that you would be like, wow, that's crazy?
I can't say I'm shocked.
No.
So.
What helped them? External laryngeal manipulation helped them. We talked about that with our UV scope rollout. I believe that's key. We've talked about that being key. It helped them in this study. Bougies, That's interesting.
Sounds familiar.
You know where you might find a bougie, anyone? Hopefully in all of our intubations, both cardiac arrest and non-cardiac arrest, DSI. And then position changes. That's a big one that we underestimate when the sweat starts pooling in our armpits and the heart rate goes up in the intubator. Simple stuff like changing position, changing your level of neck flexion or hyperextension is important. This is a reminder that in this study it worked. So there's some pretty good take-home points here, even though it was 2016 or 2017 in France with doctors intubating. Cardiac arrest intubations are risky. So let's go back to the original question that we get asked, and I'll ask it to you. Why don't we intubate our cardiac arrest, Dr. DePasquale?
Because we don't need to, right?
Yeah.
There was this big change to CAB from ABC years ago, right? This is not novel. This information's been out. Airway management's kind of the last priority on the scene of cardiac arrest, right? You getting on scene, getting patches on, seeing the rhythm, doing good quality CPR. The airway gets managed in that you start bagging them, but taking the time to get all the equipment out and get the laryngoscope in their mouth and get an endotracheal tube in place is just not the priority when you're doing active CPR. Put the eye gel in, it works. You know, there's very few instances where it's a priority, and I would say probably if the cause of the arrest is airway in nature, if there's a big obstruction or food bolus or something, then that's probably the priority after you get the other stuff done to remove that. But barring that, and in most of these cases we presume cardiac etiology, it's just low in the priority list.
We talked about a recent finding that we've seen from watching our own UE scope videos, Chief Smith, that we will likely add a line into our protocols, I believe, and that is what do we have to have ready and lead with in our cardiac arrest?
Suction.
Suction.
Have to have suction.
These are soiled. These are always soiled, so let's just say we're going to do it every time. I don't normally like reading out of studies, but to Dr. DePasquale's point and really summarizing what he just said, this is a paragraph, a couple sentences from the discussion of this study, and these are coming from European airway experts in the Journal of Resuscitation. Here's what they said. When managing cardiac arrest, it is conceivable that intubation is not a priority in the early phase. If ventilation is possible using a BVM or a SGA, IGEL, circulation should be prioritized. Sounds familiar. Dr. DePasquale just said that in other words. Intubation could be performed at a later stage after ROSC, for example. If ventilation is not possible via either of these two systems, then intubation should be considered and optimized using a bougie and VL. Hey guys, I mean, to the MCHD listeners out there, that's our foundation. So to hear that quoted, written by experts in the European Journal of Resuscitation makes me feel pretty good as a medical director, like we're on track and we're not off in the wilderness with our cardiac arrest management priorities. Chief Smith?
Yeah, I mean, it's pretty clear that these cardiac arrest intubations are risky, and they're risky from multiple different standpoints, one of which is, I don't know that we necessarily hit on this quite yet, but it detracts from other important things. And you talked about that in the sense of, you know, we want to prioritize compressions, we want to make sure that we're defibrillating as needed, et cetera. But I mean, with that, when you're focusing on an airway, something that's not the primary, or in the case where it's not the primary cause, like you alluded to, we don't want to detract from the two things that we know are going to work, which are those compressions, which is defibrillations. We have to focus on what's right for the patient, and we can take away from that when we focus on an airway.
So no one's saying we don't intubate cardiac arrest. No one's saying that we can't intubate cardiac arrest. It's intubate with a purpose and for a reason. Prioritize compressions. Start with the supraglottic and make your moves from there as the patient's progression directs. And that's going to depend on each individual case. But here's some pretty good evidence that our protocols are lined up pretty well with what the experts would have us believe. There was a second study that I didn't delve into, but I thought y'all might want to hear about this one because it was kind of cool from the medic standpoint. There was a second out-of-hospital cardiac arrest airway management study that was in the Scandinavian Journal of Trauma and Resuscitation and Emergency Medicine. And they surveyed paramedics and docs who were intubating cardiac arrest patients. And guess what? There was no difference in how well the docs and the medics did. But there's a downside, and both did pretty terrible. Their first pass success in that study was 63%, even worse than the one we discussed. So medics, docs, all of us are bad at intubating these patients. So let's prioritize oxygenation and ventilation by easier routes and really concentrate on that circulatory side of things. So if you wonder where our cardiac arrest airway foundations come from, that's a brick in that foundation. Let's talk about a brick in really the last year. And we've moved from the King Vision to Scope here at MCHD. We've talked about that on prior podcasts. This study was interesting to me because we specifically chose standard geometry blades, Mac style blades, with our VO. And this study looked at the other end of that spectrum, and it looked at hyperangulated VO in the emergency department. And they were specifically targeting errors and factors that led to apnea. So in other words, when did we muck around in the airway too long and leave the patient with a lack of oxygenation and a lack of ventilation? So they were using recording VO, just like we do here at MCHD. The difference was they were using hyperangulated blades. So this was by Bryan et al. In the American Journal of Emergency Medicine from May of this year. This was single center and retrospective, so this was at George Washington in DC. Looking in the rearview mirror, they looked at airways in their emergency department over a 2-year period, 2022 to 2024, and they looked at 100 hyperangulated VL attempts. These were emergency medicine residents, and their outcomes that they were looking for was first pass success and the errors that folks made. If you're curious about their device, they use a glide scope with a stylet, kind of operator's choice. What'd they find? They did pretty well. First pass success, 85% in these residents. I feel pretty good about that. Our first pass success right now is hovering in the 81 to 82% range with a brand new device that everybody's still getting used to. So if you want to compare apples and apples, pretty decent comparison there. Makes me feel pretty good. I think you all would agree.
Yes, sir.
Mm-hmm.
They saw the vocal cord in about 7 seconds, so pretty quickly we're able to identify the cords, deliver the tube in 26 seconds. Right now, our median tube delivery time is right at 30 seconds, so again, comparable. Here's where the meat and potatoes and the good stuff comes for me, is that they found an error in it in 2/3, so well over half of their successful intubations, they found an error. Now, why is that interesting? Because some might say, why are you sending us all these feedback on these intubations, doc? We got the tube. Like, leave us alone. Well, yeah, we could. Or we could look at those successful intubations and try to find tips, techniques, ideas for the next one to make it even better. What were the errors? And Chief Smith, I'll let you take the errors here because you could have answered these errors from our own experience. They match up exactly.
Yeah, it's wild how that's the case. I mean, it looks like we're reading a summary report of our own airway reviews here. Blade placement was about half the time. We either had, or in this case, they had the blade too deep, about 55% of the time. In a number of our videos, especially for the MCHD listeners, you'll probably see quite a few comments from Dr. DePasquale, Dr. Patrick, hey, back it up a little bit, make sure you're getting into that molecular space. The second thing is in that subcategory is off midline. So you want to make sure at MCHD we say you want your crosshairs to get in the center of the screen. In the center of the screen, you want that glottic opening. And then the third one beneath that is too shallow. So again, move towards the molecular space. As far as tube placement difficulty, that was one aspect. And Dr. Patrick, you've said this a few times now, but lack of suction.
They also had some in there where there was suction running around in there with no need for it, and we have seen that video as well.
Yep.
So really, if you take these errors and the order they found them in, I believe if you overlay them on ours, paramedics in the field at MCHD, I think they're exact because it's blade placement is over half the errors, check. Most of those are too deep, check. Some are off midline, some are too shallow. And then suction either needed and not used, or used and not needed. Would you agree, Dr. Pasquale?
Yeah, absolutely. Sometimes we see these beautiful looking airways, and I'm like, okay, where's the tube? And then I see the suction catheter, and they're just picking up that little bubble, little spit on the side of the corner of the mouth. I'm like, okay, it's pristine now. Let's get the tube in.
I can see the cords. That one little speck is not going to block us. And then other times you see gastric contents like crazy and no evidence of suction whatsoever. And it's impossible for us to know. Like, we are literally the biggest armchair quarterbacks in the world in this process.
Oh, yeah.
I mean, I know I've watched my own and rolled my own eyes at myself, so I get it. It's a disconnect between all the things that are going on off video screen. All we're looking at is the airway. I don't know what's in your hand. I don't know what kind of help you have. I don't know what god-awful situation you're in. So there is no judgment from the standpoint of, we're not degrading anyone here, but we've got an opportunity to make the feedback, so let's make it. Chief Smith, what helped in these airways? Because this is going to sound markedly familiar to our cardiac arrest study and to some of our feedback that hopefully we've given both in CE settings, in training settings, and in our medical director feedback.
Yeah, so 3 big things that helped. The first one was ELM, or extralaryngeal manipulation. The second thing that helped is switching to a bougie.
Hey, you better have it in place.
And the third thing that helped was position changes.
So don't forget the simple stuff in both of these studies. Little external neck pressure, having the bougie prepped and ready, which you better have anyways. Hopefully we've solved that problem. Position changes is one that I know in airways I look back on and don't feel great about. I always could have changed that position sooner. It's just something in the heat that gets forgotten. So put the blade in the vallecula. That's going to give you your best shot. Put that in midline, and then we're on track. To me, this sounds like we are on track as a service here at MCHD because these numbers and errors match where we are today. They wrote a very interesting paragraph that sums up the reason why we as a Department of Clinical Services and as medical directors and Division Chief of Clinical wanted recording VL capacity from the very beginning. And this is coming from the emergency physician leaders in this emergency department. They said, similar to other investigators, we have begun to implement into our training program a review of intubation videos that have teaching points. This occurs via quarterly presentation during emergency medicine grand rounds. Introducing this type of formalized review offers the opportunity for more junior residents or for younger paramedics to see a broad range of patient anatomy for future intervention and early intervention to occur if new error types are observed to develop. So in other words, young folks get to see more before they start to make mistakes. They can be headed off at the pass. Anybody heard that before? That better sound familiar because that's what we've stood up in front of CE and said for the last 6 months. In the future, we plan to develop a process for linking the intubation attempts to the providers performing the procedure so that individual feedback may be given. Dr. Pasquale, what did you spend the morning doing today?
The airway review and feedbacks to the individual medics who did the intubations.
So if you're an MCHD listener out there, these folks in the George Washington Emergency Medicine Residency Program, the GW Emergency Department, they hope to in the future have what we have today here at MCHD. So I don't say that to brag, but I kind of do say that to brag because we feel like this is vital. Why? Analogous to what has been shown with trauma bay reviews, it is our expectation that a formalized review process will lead to improvements in first pass success, reduced apnea time, and decreased adverse events. So why are we sending y'all these reviews? Why do we care about these errors that are made in successful intubations? Because we think it's going to improve our patient outcomes. Chief Smith?
Yeah, anecdotally speaking here, but it really is neat when we review a provider video and they've received medical director feedback, or we've brought them in, or they've come in on their own volition and have said, hey, this is the feedback we've received. This is how the last intubation attempt went. I'd like to practice that, or I'd like to put your feedback into practice in a training situation. And then they go back out there, they get another intubation, and it is beautiful. They have great positioning, great use of suction. We've seen cases where ELM really did come and save the day. And we're really just so lucky. I agree. It is something to brag about. It's also something to be extremely grateful for. 100% medical director feedback on all airways with the opportunity to educate and remediate with training equipment. Super, super huge leg up in the clinical department.
And who's the one that's taking that feedback and actually making the changes? It's the medics out there doing these intubations in the field. You know, the guidance and the mentoring from our district chiefs and captains here at MCHD has been huge. So this takes the entire group to make this happen. It's not just on the medical direction or the Department of Clinical Services team. This is a group initiative, and it focuses on the patient and the patient outcome, which to me makes it win-win-win. What do you want to add, Dr. DePasquale?
Well, to the MCHD listener about the airway feedback, I think sometimes we don't have exactly the same goals when we're looking at the airway stuff. If there's a case and we're giving feedback and there's some pointers or room for improvement, I'm giving this feedback and we're looking at it and giving some detailed feedback on kind of things that could have gone differently or steps that you could have taken during the intubation. And like Dr. Patrick said, that's for preparation for next time. We see that you got the airway. We're excited that you got the airway. We're happy that the airway went in, but next time it may not. There are several situations that we have seen where sometimes we just get lucky. Sometimes we're in an off angle, or we're off center, or we're too deep, or the airway's all soiled, and we just, luckily, the angle was right. Luckily, it got in. Luckily, the camera didn't get bloodied, right? But next time, under the same set of circumstances, you very well may not get that airway at all. So the point of all that feedback, even though you got the airway and it's a win for sure, is that next time you have a similar situation, you can avoid kind of the same kind of pitfalls that you avoided this time, but now with some repetition and some feedback. And the thing I like the most about the feedback we give is that we do it on our messaging service. So the crews message me back and we have a discourse about it, a little chat sometimes about, because I'll have questions too, like you said, all I see is the inside of a mouth, right? I'll ask some questions and they'll go, well, that's because there was a dog biting my ankle or something. And I'm like, oh, okay, I guess that makes sense. But that's the part I like the most.
And y'all are receiving your airways. We include all the providers on the scene, the district chief, the in charge, the attendant. Every one of these airways is getting a fine-tooth comb, and it's not personal. It is because we, like these experts and the authors of this paper, believe that emergency physicians, anesthesiologists, paramedics will do better overall with their intubation technique and their intubation success if they're learning from each one of their attempts. I mean, I don't know if you all have kids that play golf or play baseball or ski, or you take any high-level athletic activity today, and folks are being filmed and critiqued based on their film. This is no different. So let's wrap it up. Why do we use iGels first in CPR? Because intubating patients in cardiac arrest is hard. Why? Because they're getting compressions and they're vomiting, mainly 1 and 2. Nobody is good at intubating out of hospital cardiac arrest, not physicians, not paramedics. So yes, we can intubate them. We want to intubate them selectively, carefully, with good preparation. External laryngeal manipulation, it helps. Bougies, they help. Position changes, they help in both of these situations, both in VL ED department studies and in French out-of-hospital cardiac arrest, medics on truck studies that don't really match us at all, but they do match us in that the simple stuff is what worked. So don't forget those things. Put the blade in the vallecula, not too deep, not too shallow, not off midline. You're going to have more chance for success. And we believe, and hopefully we can get y'all on board with this, and I know it's been a process that we're building, but this is meant to be constructive. It's meant to be improvement and technique-based and not demeaning or negative or punitive. We want us all to get better. I learned from watching y'all's videos. I learned from watching my own. We feel like this is going to be standard of care in 5 to 10 years across intubation. And so this VL feedback that we get, and we're lucky to have a system where we can provide these videos to everyone, to all the folks on the calls. It's key for us to be long-term proficient, because the dirty secret for all of us, I believe, emergency physicians these days, and especially our paramedics in the field, we don't have enough of these to suffice. We need every bit of growth opportunity that we can have, and watching these videos is huge. Even successful intubations have learning points. So I'll close it up there and leave the last words to Chief Smith and Dr. DePasquale.
Yeah, I'll say for any of the non-MCHD listeners, we've done a podcast about VL implementation, recording VL implementation already, but if you have any questions, comments, if you're looking at implementing this in your own service or even just considering it, funding, anything towards that side, please don't hesitate to reach out. We are more than happy to share what we've learned, and we will share everything, good, bad, and the ugly. More than happy to expand on that.
We love watching these Airway videos, and if you have any questions about the video or about intubation that you weren't sure about, just come ask us, shoot us an email, send us a WebEx, let us know. We'd be more than happy to have you come down and play with the mannequin and get some reps in and get some tips in person. We're happy to do that.
As always, thanks for listening and watching. Wherever you watch or listen out there, please subscribe, leave us a like, leave us a review. That gets us out there and gets us more visible. If you have ideas for future podcasts, if you want any information on our VL approach here at MCHD, please shoot us an email, podcast@mchd-tx.org. This is part 1. We've got a couple more articles which really lead into Airway Foundation learning points. If you can't tell, we're not going to spend a million hours dissecting the confidence intervals. We're going to use these articles to jump off to answer the Airway Foundation questions that we get here at MCHD. So thank you for listening. Thank you for watching. We'll be back with a new episode soon.